Hello, I'm LL, and this presentation is on transcranial direct current stimulation for the treatment of major depressive disorder. Major depressive disorder, MDD, is a severe chronic psychiatric illness which has been reported among the top 5 most disabling diseases worldwide. Abrametz and others reported in 2015 that MDD is associated with increased risk of suicide as well as other illnesses such as cardiovascular and metabolic diseases. Brunoni and others reported in 2012 that at a neurophysiological level, MDD is characterized by decreased activity in the left dorsolateral prefrontal cortex and an increase of activity in the corresponding contralateral region, resulting in interhemispheric imbalance. According to the Kahneman 2016 guidelines, current treatments include pharmacological approaches, various methods of neurostimulation, physiological therapies, and a variety of physical, meditative, and natural treatments. However, Bernabe and Haffen reported 30% of patients are not benefiting from current treatment. Transcranial direct current stimulation induces an electrical field between electrodes, an anode and a cathode, applied to the scalp. As current travels between the two electrodes, the region under the anode slightly depolarizes the neurons of the brain region beneath. This increases the chance of a spontaneous action potential occurring in that region. At the cathode, the brain region is hyperpolarized, reducing the likelihood of action potentials occurring. When tDCS has been applied as a treatment for MDD, studies have used a variety of electrode montages. The most common of the ones pictured here places the anode at F3 and the cathode at F8. The anode, in the F3 position, aims to depolarize the neurons of the left dorsolateral prefrontal cortex, while the cathode hyperpolarizes neurons on the contralateral side. This aims to rectify the interhemispheric imbalance characteristic of MDD. tDCS has been a successful treatment according to several studies. Segrave and others in 2014 found tDCS to be a successful treatment for 27 MDD patients when administered concurrently with a cognitive control therapy, CCT. While tDCS induced depolarization in the left dorsolateral prefrontal cortex, cognitive control therapy excited neural activity in that same area. In comparison to sham tDCS groups and sham CCT groups, cognitive control therapy and concurrent active tDCS was most successful and remained so at a 3-week follow-up. These results were replicated by Brunoni and others in 2014, who also found concurrent tDCS with CCT to reduce depressive symptoms. Aparicio and others conducted a 6-month follow-up study assessing whether tDCS is effective for the maintenance phase of treatment. 24 patients who responded positively to a primary tDCS intervention received twice-weekly tDCS for another 24 weeks. Results showed relatively low relapse rates after 6 months of follow-up of the tDCS participants. In contrast, a number of studies have not found tDCS to be an effective treatment for MDD. In 2010, Liu and others compared the effects of active tDCS with a sham protocol in a sample of 40 participants and found there was no significant difference between the groups. In this study, however, some participants were not taking medication, some remained on medication they weren't responding to, and some were taking antipsychotics. In another study by Liu and others in 2012, participants on medications known to moderate tDCS effects were excluded, while some remained on medications due to clinical reasons. tDCS showed significant antidepressant effects compared with sham protocol, but this was reported as clinically modest, and the results were only true of 1 out of 5 mood rating scales. In a study by Bernabe and others in 2014, 24 participants were prescribed 10 to 20 milligrams of escitalopram and assigned into 2 groups, either receiving active tDCS or a sham protocol. While both groups showed a marked improvement in clinical and self-report measures, there was not a difference between sham and active protocol groups. The literature reviewed here suggests that tDCS is an effective treatment for MDD, most promisingly when administered concurrently with cognitive control therapy, but also administered in the maintenance phase of MDD treatment. However, the research shows concomitant medication appears to hinder the utility of tDCS. Participant numbers in these studies tended to be relatively low. As such, future studies should look to replicate these findings with larger samples and to also clarify the medications that augment and the medications that hinder the usefulness of tDCS.